I'd like you to pass it around and have everybody sign it. Oh, that's pretty. You. Okay, then I'll be the first to sign it. Borrow a pen. And make sure you pass it around to everyone. Oh, yeah, so everyone gets it. Okay, cool. So Morgan brought a card for Bethany, and Bethany had to discontinue her participation in this class. She's going to pass it around. If you could please sign, and we'll get that off to her just as quickly as possible. Good to see an all-school class here, for the time being at least. So we'll go for that. Lab is approaching its end, so you're done with biochemical tests. We now will do some specialty labs about strep and staph and pneumococci and Neisseria, and then hopefully you'll be able to key out your personal isolates from your own body, and that should be fun, and then we'll be done with lab. So for today, I want to finish the antivirals, and then we'll move on to chapter 13. All right, I feel like we should have a word of prayer to start with. Lord, thank you once again for a new week. We pray for every student here. Some are coming back from quarantine. Some are just coming back. Thank you for every student here. Now, Lord, please keep us healthy. Help us to go forward in the strength you've given us. Help us to learn of you, learn how to take care of others in Jesus' name. Amen. All right, did you all get the handout? I emailed it to everyone. Did you get a chance to print it out? You did. Did you bring it with you? And I see some reaching for it, so that's a good sign. I see others pulling it up on their computers. That's a good sign too. So let's go ahead and use this now for our discussion of the drugs that are used to fight HIV. So as we said before, HIV is an RNA genome. It's a retrovirus. Goes retro, reverse. It listens to music from the 1900s. It goes from RNA to DNA. That's why it's retro. So it uses an enzyme called reverse transcriptase. That's not an enzyme we have in our bodies. So that's a target for drugs. It integrates the DNA into our own genome. There's an enzyme that does that called integrase. That's a target too. It produces viral proteins. By pressing those genes, those proteins assemble into virions. That virion assembly requires the activity of a protease. That is a target for anti-drug treatments. It then lyses the cell, they leave the cell. The fusion of the virus with the cell, that's a specific event. That's a target as well for drugs that are used to treat HIV also. So we very quickly went over this. I don't want to belabor the points here. Suffice it to say that the virus is going to attach to a very specific receptor. That's the CD4 protein on the surface of T helper cells, CD4. And there are antibodies that block CD4. They will prevent the virus from infecting. Those are available as well and can be used under emergency circumstances. So your armamentarium will consist of things that inhibit viral entry, things that inhibit reverse tryptase, things that inhibit integration, and things that inhibit the viral proteases. That's your quiver. These are the arrows in your quiver. You never treat HIV with just one drug. You always treat it with a drug combination. That drug combination constitutes a so-called highly active antiretroviral treatment. And this is what's known as HAART. You don't treat with one drug because the reverse transcriptase is very error prone. Creates mutants. Therefore, the tendency for the virus to create mutants that are now resistant to your drug treatment, that tendency is very high. Because that tendency is very high, you treat with more than one drug, and it will therefore greatly decrease this tendency for your viral strain that's infecting your patient to achieve resistance to your drug treatment. Now, does resistance occur? Yes. With a combination treatment, however, it's much less frequent because now you have to have multiple events that cause resistance, not one event. That make sense? Sweetheart, can you put your mask on, please? Thank you. I know, we forget. Okay, so the reverse transcriptase inhibitors come in two types. Nucleoside and nucleotide reverse transcriptase inhibitors. These mimic nucleotides and nucleosides. They get into the cell sniffs them and says, looks like a nucleotide. It's or a nucleoside. It's phosphorylate. Now it can't leave the cell, and it gets incorporated into the growing nucleic acid chain. Because it is chemically aberrant, it will not allow proper elongation of that nucleic acid. You terminate nucleic acid production, and you terminate productive viral infection. So the nucleides, they terminate elongation, synthesis of nucleic acids. Then there's non-nucleotide reverse transcriptase inhibitors, or sometimes called NRTIs. These bind to the reverse transcriptase at a different site other than the active site and gum it up. So let's say you want to inhibit the lock on that door. You could, if you want to prevent someone from putting the key in, you could take your chewing gum. Don't do this, by the way. You could take your chewing gum and smear it all over the lock, the keyhole, so the lock couldn't come in. Would that gum it up? Yeah, that's kind of how these nucleotide reverse transcriptase or trace inhibitors work. Alternatively, you could probably take that lock, you could probably go in through the hammer, the door hammer, and you could probably take one of the pistons out because there's little pistons in there as you turn it. If you took one of the pistons out, you could brush your key in all day long, nothing would happen. That would be going in through another direction. Would that inhibit the lock? Yeah, it would. So that's kind of how the non-nucleotide inhibitors work. They bind to a different site on the enzyme, and they inhibit the enzyme in that fashion. So here is a list of the nucleoside inhibitors. Now, there's two I want you to pay particular attention to. This one here, tenofovir, and this one here, emtricitabine. The reason I want you to pay particular attention to those is that those two are the best tolerated of this group of drugs. So most of your cocktails will have one or maybe both of these drugs also. These drugs are approved for something called, now PrEP, it's like a pet training program, I realize. That stands for pre-exposure prophylaxis. Pre-exposure prophylaxis. Does anybody know off the top of their head what pre-exposure prophylaxis is? No one's heard that term before. You've probably heard it once I tell you, you're going to say, oh, should have had AIDS. If a pregnant woman has HIV and she does not wish to pass HIV to her baby, these are the drugs you would give her to suppress the virus, knock the virus levels in her blood down, and prevent her from passing the virus to her baby when she gives birth. That's called pre-exposure prophylaxis for the baby. And tenofovir and emtricitabine are safe for a developing baby. And they are given to pregnant mothers who have are pregnant and are HIV positive. So they're part of the pre-exposure prophylaxis. Now, from your handout, you'll also notice hepatitis B also uses a reverse transcriptase. It's a DNA virus, but it makes a genomic RNA. That genomic RNA is hooked into a cell, and then that genomic RNA is reverse transcribed to make the viral DNA. So some of these drugs also can be used to treat hepatitis B. That's a bonus because some people with HIV are intravenous drug users. Intravenous drug users also tend to be co-infected with hepatitis B. So by treating people with drugs that hit both HIV and hepatitis B, you get a bonus. Now, downside is, if you take them off that cocktail, their hepatitis B is going to really, really rise, something fierce. So they're going to have a relapse of hepatitis B. So of these, emtricitabine is active against hepatitis B. So is lamivudine. And as you can see, so is tenofovir. Those are the three drugs that are also effective against hepatitis B. All right, and then some of these have particular side effects that have been noted. These three here are the most toxic and therefore are used the least. Definitely used the least. That's why they're second line. So your adverse effects, that means side effects. GI disturbances is probably one that occurs the most often. It can range from, I've got our stomach, to, oh my goodness, where's the bathroom? I'm going to upchuck. To, oh my goodness, where's the bathroom? It's coming the other end. Or all the above. It could range pretty wildly. Bone marrow suppression. That is more severe in some of these than others. CNS toxicity. That is less common with these two and this one than it is with any of these others. And then various metabolic effects. Those are your main side effects. All right. Those are the nucleotide reverse tryptase inhibitors, or the so-called NRTIs. Every heart cocktail contains one or two of these. Every one. Okay, any questions about these particular drugs? These are given orally, by the way. All these drugs are given orally. So they are incorporated into the growing DNA chain. They terminate it. You don't get productive infection. And these, as you can see, are some of the side effects. Now, tenofovir comes in two forms. It comes as a prodrug. Those two forms, depending on the dose, will cause nephrotoxicity. That tends to be dose specific. So it can be the worst, but it's also dose specific. If you have it in a cocktail where it's a part of a combination treatment, you don't tend to see nephrotoxicity, except in people with low kidney function in the first place. Abacavir can cause really severe hypersensitivity reactions. Tends to occur most often in people of African descent who have this particular allele of the human leukocytogen B5701. That is a protein found on the surface of white blood cells. And that allele tends to be found in people of African descent. You can screen people. There are ways to screen this. You can send this off. If someone has this allele, they should not be put in abacavir. Their chances of having a severe hypersensitivity rates, and they're simply too high. And here are some of the drug combinations that contain these various drugs. Trevada is one of the combinations that's used for pre-exposure prophylaxis. And you can see some of these others here that are available. And they come as various drug combinations. Most of these are designed so that you only take one pill a day, which is very convenient. The cost of these, I actually have that somewhere. So Trevada, for a month supply of Trevada is about $1,500. So it's not cheap. Trizavir is an older drug. A month supply is about $500. So it's a lot cheaper. So a year's supply of this stuff it gets up there in price. So many drug companies now will provide ways for people to get drugs at reduced prices. So it's very rare for HIV patients not being able to afford their medicine in many cases. Now, non-nucleoside RT inhibitors must be given with a nucleotide inhibitor, a nucleotide reverse transcriptase inhibitor, because these drugs have a tendency to induce resistance at a higher rate. So if you give these, you have to combine them with an NRTI. Of these, I'd like you to note this one, efavirenz. Efavirenz does not interact with anti-tuberculosis drugs. So this drug is used if your patient has HIV and tuberculosis, which is actually more common than you would think. And then here are the others you can read. So I have various drug combinations with these as well. Atripla, Complera, so on and so forth. So here you can see this is combined with both emtricitabine and tenofovir. This one here also combined with emtricitabine and tenofovir. And those are examples of drug combinations. So again, these bind to a site other than the active site. They tend to cause a lot of side effects. Nevirapine is the biggest offender in terms of hypersensitivity. They also tend to cause rashes. Nevirapine is the worst offender here. And they can cause CNS effects. They can cause insomnia and sometimes pretty vivid dreams. There's also maybe depression, some psychosis. That's rare, but it has been reported. And then dizziness, drowsiness in some people. Again, the drug manufacturer says these are minimized if you take the drug on an empty stomach and take it 2 to 3 hours. Where'd my H go? Oh, there should be an H there. 2 to 3 hours before bedtime. That can minimize that. There's also some metabolic effects. Hypertrophy of adipose tissue. That's particularly the case in diabetic patients. Hepatotoxicity is not hugely common. The issue with these drugs is that patients are on lots of other drugs that are metabolized by the liver and also have liver toxicity. That's usually when your hepatotoxicity really starts to make itself known. So they have a variety of drug-drug interactions, unfortunately. If your patient has not been treated before for HIV, the NNRTIs are first line. In patients who have been treated before, they tend to be second line because the virus that patient has will more likely not be resistant to them. So it's not uncommon for patients to get transitioned from one drug cocktail to another, to another, to another. Protease inhibitors. These prevent the proper maturation and packaging of the virion particles. You don't get productive infection. And you'll notice that these will tend to end in navir. Navir, that is an ending all these drugs have. All right, so the protease, it's an aspartic acid protease, and it will cleave. You make a precursor that's a bigger protein, the protease clips it in half. So now that you have the two separate polypeptides, and the protease inhibitors prevent that from happening. Without this cleavage, you don't properly assemble the particles, and they exhibit nice activity against lots of different clinical isolates of HIV. Also, if you start to get resistance to one of these, typically what happens, as you can see, the protease, the crystal structure, is a dimer that tends to look like this. And the protease, in order to induce resistance, the protein tends to widen its active site like this, so the protease inhibitor can't be more, but there are protease inhibitors now that fit the bigger one, so you can transition to a bigger one that now inhibits. Then if it starts to go back, you can transition back to the smaller ones. This is something that's very easily dealt with, resistance to protease inhibitors. Now, the problem with protease inhibitors is they have a lot of side effects. So they can be kind of hard on the liver. They can also be kind of hard on the GI tract. That's not as much of a problem if you give them with food. You should have increased risk of myocardial infarction and strokes. You get fat accumulation, and you can get precipitates in the kidneys. This, however, can be mitigated. It can be dealt with if you have adequate fluid intake. Because of the gastrointestinal issues, people don't tend to drink. They also lose a lot of fluid because of upchucking. That tends to exacerbate the kidney issues. So adequate hydration can prevent the kidney issues, and taking the drugs with food can mitigate the GI issues. So there are combination treatments. These also, there's an agent called ritonavir. It's a so-called boosting agent. Let me explain how boosting works in just a bit here. So your drugs come in by mouth. What's the first organ that sees, absorbs food from the GI tract and absorb drugs? That material goes where first? From the stomach, it goes into the portal system, which takes it to the liver. So your drugs are metabolized by the liver, and drugs that are taken by mouth sometimes will get degraded very quickly by enzymes in the liver. So boosting involves the use of compounds that inhibit those liver-based enzymes, so that now your drugs will have a much higher concentration in the blood, and that concentration in the blood will cause advanced antiviral properties before the liver finally deals with the inhibitor, and then your concentrations will start to come down. So this is called boosting. And ritonavir is a boosting agent for your HIV drugs. So some cocktails will have ritonavir because it inhibits enzymes that degrade these drugs. So boosting, it is a strategy commonly used in anti-HIV treatment. And ritonavir, there are several boosting agents. Ritonavir is one of them. So you combine this with the protease inhibitor lopinavir, and now you have boosted concentrations of lopinavir. The combination is called Kaletra. And these are available in other combos as well with NRTIs, NRTIs, so on and so forth. Integrase inhibitors are probably some of the newest of these drugs, anti-HIV drugs. They're also some of the most effective. So the newer guidelines for heart combinations all recommend the presence of an integrase inhibitor in your heart cocktails because they're quite effective. So initially developed for HIV, they could potentially be applied to other retroviruses as well. They block the spread of the virus to other cells. They're very, very good at that. So your handout has 3 of these drugs. There's 2 listed here. There's actually a new one now that's available as well. So there's 4 of these now that are available. Big thing about these particular drugs, you cannot take them with antacids. If you take them with antacids or any sort of polyvalent cation, milk of magnesia, something like that, they interfere with absorption. And a boosting agent that's given with the integrase inhibitors is this drug here, cabicostat. So cabicostat is a boosting agent for your integrase inhibitors. Ritonavir is a boosting agent for your NRTIs, your nucleoside, ribonucleic reverse transcriptase inhibitors. Cabicostat is a boosting agent for your integrase inhibitors. And here are a couple of combos that contain these integrase inhibitors. Genvoya, notice Genvoya has cabicostat. And notice these all end with gravir, or tegravir. So there's elvitegravir, valtegravir, dolutegravir. So Stribled also has the boosting agent here. And then Genvoya has this boosting agent as well. There are now FDA-approved drug combos that just have two drugs. They contain a NRTI and a integrase inhibitor. And there are a couple of these now that are available, just two drugs that are used for anti-HIV treatments. That's how well these integrase inhibitors work. So cobicostat, boosting agent, we talked about that already. As HIV, anti-HIV treatments go, these drugs are relatively well tolerated. That's the other reason we use so much. They will interact with rifampin. So if you have a patient with tuberculosis and the rifampin, you don't want to use drugs with integrase inhibitors. They can increase creatine kinase concentrations. What's creatine kinase a marker for? Anybody remember? Or has anyone heard? That's more a med-surg thing. You guys have med-surg next semester, right? Yeah. Creatine kinase is a marker for skeletal muscle damage. Skeletal muscle damage. Now, usually, if you're getting muscle breakdown, you'll get weakness. This tends to be asymptomatic. You don't need to see weakness, so there's debate about whether or not this is a big deal. Some patients also have increased LDL with these drugs, but usually HIV patients, trying to get them to gain weight and getting their LDL up is usually an issue, so that's usually not much of a concern. Very good. Let me just pause right here, see if there's any questions. No? Okay. Entry and fusion inhibitors. Entry and fusion inhibitors. So these are going to prevent the interaction of the glycoprotein on the outside, that glycoprotein from fusing with CD4 and causing productive infection. So it prevents fusion, and these will prevent the virus from entering cells and causing infection at all. So there's two of these. There's envirotide. That's an injection the patient gives to him or herself. It's taken BID twice a day. Once in the morning, once again 12 hours later, usually before you go to bed. Then there is an inhaled form of this called Miraviroc, excuse me. Sorry, that's a pill, not inhaled. I'm thinking of something else. That's a pill. That's taken twice a day. So Miraviroc causes in some people cough, fever, dizziness, headache, nausea. That is, oh, those are probably 5 to 10% of patients get those. Some have increased liver and heart problems. That's a low percentage. Some show increased risk of infections. That's also low percentage. And fuvaritide, itchiness, is actually kind of common. Antihistamines seem to reduce that. Swelling, pain at the site of injection. And then others include fatigue, numbness in the feet or legs, low percentage, but significant enough to be reported. Dizziness and insomnia. Fatigue is probably the one that's reported the most often. So these are used as add-ons for your tough to treat cases. In that case, they do reduce viral loads. Maravirac will only inhibit those HIV strains that use the ancillary receptor, CCR5, the chemokine receptor, as its main receptor. It's not effective against those that use C4 as the main receptor. CCR5 is a co-receptor. As the virus settles into the body of the patient, and as it goes through many, many rounds of infection, it will tend to use CCR5 as the main receptor. So this is a drug that's usually going to only work in people who've had the virus for a while. Okay, questions about HIV drugs, HBV drugs, hepatitis drugs, anything like that? A lot of info here. Some of you will almost certainly care for HIV patients. Some of you maybe already have cared for HIV patients. It's a tall order. It's a tall order. They have a lot of meds you have to keep track of, and they can get sick at any time. Sick with things that are just inexplicable, it seems. Okay, let's go ahead and take our break now, and then we'll look at drugs for hepatitis C. And that'll be it with drugs after this. Dalen, can you hear me all right? Can you just unmute yourself and tell me?
Yeah, I can hear you.
Okay, are the slides moving?
Yep.
They are? Okay. Let me just,
And I know Keegan, she's kind of having trouble getting into this Zoom.
really?
Yeah.
Okay, let's see. Are the slides moving?
Yeah.
They are, okay.
Yep.
She's having trouble getting in. So the
Yeah,
link
she said
works
she had
for
a
you?
problem on Friday too.
Really?
Yeah.
Okay, I'm not sure what to make of that. I'm inclined to think it's her computer.
Yeah, that's what I was thinking. So I told her I was just taking notes for her.
Okay. She's quarantined. She can't leave her room, right?
Yeah, we get done on Thursday. So we'll be back in class on Friday.
Okay. Well, this will be recorded, so I just encourage her. I know that's frustrating for her, probably. Yeah, she had that problem before. Morgan told me she was having trouble, and because other people were able to Zoom in, the only conclusion I have is that it's her computer. Has she called IT?
I don't think she probably even thought about it just yet.
You know, if you're in contact with her, in fact, maybe I'll have Morgan text her, have her contact IT, because it could be, some people have, for Zoom, they have some sort of program that has a background that runs that prevents Zoom from connecting. And
Oh.
she just needs somebody to share. Yeah, there was a student who had that issue. If they just shut that off, she'll be able to connect. So, if you could text her, and then I'll tell Morgan to text her to contact IT. They might be able to fix that. Okay?
Okay.
Okay, we're on our break now. We'll resume in about 3 minutes or so. Okay?
Okay. Thank you.
You feeling better?
I actually didn't I got tested and I was negative, and so I felt fine. I feel fine. I don't have any symptoms or anything like that. Of course, quarantine can really be terrible for your mental health, but other than that, I feel good.
Yeah, I told you a story about my daughter, and I told you that story, didn't I?
Yeah.
Yeah, she called us every day. So I don't know if you called your parents or not, but yeah, it's something to talk to, someone to talk to. So
Oh yeah.
okay, well, hang in there. Thursday.
Okay, thank you.
Thursday.
Right.
Right.
Count down.
That's done? Oh, cross. It'll stick. Oh, everybody signed it. Has everyone signed this? Anyone who hasn't signed this? Okay, I will get this to Bethany. She came and saw me to have me sign the withdrawal form. It was with great sadness I signed it. So she's very sad. She really wants to be here. But, you know, sometimes life throws you a screwball instead of a curveball. And you just have to get in the box and swing as hard as you can. So I think that's what she's done. Okay. Could you please check again? And, well, yeah, I think she probably needs to see contact IT. Because I had a student in the past who had trouble, and they just had something shut off in the background. So to have her contact IT, they need to come and help her, okay? Okay, thanks again. Was it $5? Yeah. It was, okay. Yeah, you go ahead. It's being recorded right now.
Okay.
Yeah. Okay.
And I feel really bad because I want to walk out.
Okay, yeah.
If you want like a note after.
No,
Are you
no.
sure?
I trust you. That's fine. Yeah. Has to do with their stability, and some just irritate mucous membranes. The stomach, the acid is more easily irritated, whereas the more big pH of the duodenum and so on and so forth is less likely to be irritated. So keep in mind, small intestinal motility is high. The stomach, food sits there, so there's more tendency for it to irritate things. Food will tend to decrease its contact with mucous membranes. So I need to be taken on an empty stomach, otherwise you decrease its absorption, because its absorption is such that it needs to be right against the mucosa to be absorbed properly. So, and some of the tenofovir is given as a prodrug. It's tenofovir diproxyl fumarate, which is abbreviated TDF. You look at the drug combos, it'll say such and such, and TDF is tenofovir diproxyl fumarate. And then there's another one called tenofovir allodenamide, and that is a different prodrug. Those two have actually different side effect profiles. TDF tends to cause bone demoralization, as where the alaminate, bromide, doesn't. So that's why some combos will have one or the other. Yeah. Okay, I believe it's time to resume. Now talk about hepatitis C. Hepatitis C, when I was a graduate student at UC Irvine, was called the yup flu. It is not the flu. Hepatitis C can cause virtually no symptoms, and then you go to the doctor for a physical, and the doctor then looks at you with a very grave look, and she says to you, your liver panel looks troubling. And you say, well, I feel fine. Yeah, but your liver function is probably about 40% of what it should be. That's not good. No, it's not. Turns out you got hepatitis C. You've had hepatitis C for a long time. But it destroys the liver very, very slowly. Hepatitis C, therefore, is more of a chronic sort of disease. You don't get the fulminant sort of hepatitis that you get with hepatitis A or hepatitis B. It is a disease that you sometimes, well, usually don't know you have. So it causes liver disease. It's bloodborne. And it's globally, it's estimated to have infected over 70 million people. And this can cause cirrhosis of the liver. Long-term infection can also predispose you to hepatocellular carcinoma, which, let's be honest, there's been a lot of advances in treating cancer. Hepatocellular carcinoma isn't one of them. Hepatocellular carcinoma is a death sentence. You can increase survivability. You can increase time to survival, but in terms of curing it, that's not really happening. So this is very significant. Now also, if you're combining that with the fact that some people may go out on weekends and drink more than they should, you're already damaging your liver. Say too, you're at a kind of job that's kind of more high stress. So to take the stress off, maybe you try cocaine or something like that. What does that do to your liver? Is that good for your liver? No. So you're already, well, because you're young and you're industable, you're already exposing yourself to things that are bad for your liver. Then you put this on top of it. Now what's happening? Now essentially you're shortening the life of your liver. So some 400,000 people die from hepatitis C, and it's usually due to cirrhosis and hepatocellular carcinoma. So this is nothing to mess with. It's nothing to mess with. So this is a enveloped virus. It's a plus RNA enveloped virus, and it has a tropism for liver. Has a tropism for liver. Now, the molecular biology of this virus is well understood. Consequently, there are targets for drugs that have been developed based upon an intimate knowledge of the molecular biology life cycle of this virus. So it gets into the hepatocyte, and the genome is translated into this very large precursor protein that needs to get clipped into individual polypeptides. So it gets clipped by some proteases. Some of these are encoded by the virus. One of these is called NS protein. Now the nucleocapsid proteins, and they are going to recruit the viral genome into a RNA replication complex. You therefore have an RNA-based RNA polymerase. Do our cells have RNA to RNA polymerases? We actually do, but they only are used to make very short RNAs. To make longer RNAs like this, no. So that is a potential target for drugs, this RNA-dependent RNA replicase. Then the protease is going to clip these. You replicate the genome, then you package it into virions, and away you go. So the NS3-4A protease inhibitors inhibit pretty specifically the hepatitis C proteases. They inhibit the hepatitis C proteases. Then you have another group of drugs for hepatitis C that are going to inhibit the replicase. And then you have another group of inhibitors that will inhibit other components of this replication complex. We will meet them as we go. With hepatitis C also, you're going to use drug combinations. You'll use drug combinations in order to treat the virus. Now, if you look at your handout, on page 4 of your handout, there is a list of interferons. When we get into the immune system, we'll talk about interferons and other cytokines. Interferons can signal, they're made by virally infected cells. They signal to other cells to turn on their antiviral machinery. And that antiviral machinery prevents those nerve cells from being infected by the virus. Interferons for years were the drugs of choice for treating hepatitis C. If you have ever had a friend or loved one treated with interferons, or if you've ever dealt with a patient being treated with interferons, interferons are a major league bummer with a capital B. They induce a flu-like state. They induce really high temperatures. They make you feel like crap with a capital C. And most patients who get on interferon treatments, you're supposed to be on them for 24 weeks, don't last 4 weeks. They just get too sick. So most clinicians now, if you can forego interferons, that's a good thing. Also, interferons knock the virus down. They almost never clear the virus from the body. Then the virus comes back, and you have to go through those 24 weeks of hell again. Most patients will say, I'd rather have the virus. These drugs don't require interferons, and they clear the body. They clear the virus from the body. This was unheard of before the development of these treatments. These treatments are still relatively new, so these drugs are still expensive, but they can completely rid the body of hepatitis C. So these are your miracle drugs, if you will, for hepatitis C. So here are the protease inhibitors. And you can see there's seven of them. And they end essentially in Previr. So if they end in Previr, they are a protease inhibitor. Then you have so-called NS5A inhibitors. Now this is a protein. It binds to your viral RNA. It's involved in replication and then assembly of the viral genome into the forming capsid to actually form a virion. So it's very, very important in assembly of viral particles. It turns out you can make small molecules that bind to NS5A and completely prevent replication. The beauty of these is that it's effective across all viral genotypes. Hepatitis C comes in different genotypes. Different can be effective for different genotypes. However, your NS5A inhibitors tend to be effective across all genotypes. So NS5A inhibitors are usually included in all drug combinations for hepatitis C. These are the NS5A inhibitors. You'll notice they tend to end in osvir, obitosvir, prevrentasvir, patosvir, lepidosvir, elbasvir, declatasvir, so on and so forth. Then you have your RNA-dependent RNA polymerase inhibitors. These types of polymerases don't occur in our cells, so these will inhibit so-called NS5B. This is what will produce the negative strand RNA molecules that then serve as templates for your positive strand viral genomes. And the inhibition of this polymerase prevents production of viral genomes. They stop a productive infection in its tracks, essentially. So there's two of these drugs, and they end, as you can see, in buvir. So fosbuvir and desabuvir are the two of these that have been designated. This one is a nucleotide polymerase inhibitor. Desabuvir is a non-nucleoside polymerase inhibitor. So there are 7 recognized hepatitis C genotypes. Before you start treatment, you must genotype the virus. You must genotype the virus. Different drugs have different efficacies when it comes to different genotypes of hepatitis C. This is easy enough to do. The virus is in the blood. You take blood, you send it off to the lab. The lab will usually commercially be able to do this, or there are kits that the lab can actually use to genotype your hepatitis C genotype. Then, based on the genotyping, then you will prescribe your drug combinations. Probably the one that's used the most these days is Harvoni. It has sofosbuvir. Sofosbuvir is a polymerase inhibitor. And then liposvir, which is a 5A, and it's 5A inhibitor. That's the one that's used the most. This combo is pretty well tolerated on the average. Vicarapac, and Harvoni originally was specified for types, just genotype 1. Most of your HCV infections genotype 1, most of them. Genotypes 2, genotypes 2, 5, 6, and 7 account for less than 2% of all HCV infections, and they're found mainly in Asia and the Southern Hemisphere and places like that. Harvoni, however, has been shown to be effective across the genotypes. That's why Harvoni is so widely prescribed. And it's also well tolerated. You give it for 12 weeks and you're through. So the Vicera pack is used for genotypes 1, and it's a 4-drug combination, and it has a booster, as you can see. For genotype 4, you see genotype 4 more in immigrant populations. So Ivy is a specialty drug for genotype 4. And then there's SAC. Sovadac is effective for all genotypes. And that has these 2 drugs here. These are some of the more, there's others as well. I think some of them are listed on your handout. Yeah, and some of them are very new as well. Blah, blah, blah. So Epclusa, Vosevi, Zapatier, so on and so forth. Those are very new. And these are the ones you probably see prescribed the most. Very good. Okay. Are there any questions about drugs in general? Any of the drugs we talked about? Anything you'd like me to mention? Lots of information, lots of things you probably have to think about, digest, and what have you, which is fine. Oops, that's what we just did. That's the one we want. Okay, let's talk about the disease process. All right. Dalen, are the slides moving?
Yes.
They are good, okay. So we've established lots and lots and lots of microbes colonizing your body. Yet you're going to have microbes that are going to colonize your body and cause disease. The difference between those that are colonizing your body right now and those that cause disease? Well, it has to do with the host-microbe relationship. That relationship has a lot of factors. It's complicated. And any organism that harbors another organism is a so-called host. The organism that is being harbored by the host can be called one of 3 things. It can be called a mutualist, it can be called a parasite, or it can be called a commensal. A mutualist, a parasite, or a commensal. What's the difference? Let's start from the top. A mutualistic relationship refers to a scratch your back, you scratch my back type of relationship. You benefit, I benefit. So the lactic acid bacteria, they're living right now in your large intestine. They're benefiting from living there. They have a nice warm host and lots of nutrients. That's better than living in soil or living in water or living in milk or something like that. Also, those lactic acid bacteria, when they die, they release vitamin B12. Release that B12 in a form that your body now absorbs quite readily and quite efficiently. So that is a mutualistic relationship. You benefit from them, they benefit from you. You scratch my back, I'll scratch yours. That is a mutualistic relationship. A commensal relationship refers to a relationship in which the two organisms live together, but nobody benefits, nobody's hurt. Nobody benefits, nobody's hurt. So for example, if you walk into the forest behind the baseball field, I don't know if any of you have gone into the forest there yet, have you? It's quite beautiful back there. I, in fact, I see Terrace nodding her head. And in fact, take a mate and go for a walk sometime back there. It's very beautiful. You might even see some mushrooms, and don't pick them. But you might find on the trees back there the fern that actually grows on the tree. That's called an epiphytic fern. It's an epiphyte that grows on the tree. The tree is not harmed by the fern. The fern is not on the ground, so it's not stepped on, but it's up there. It's a little closer to the light. Neither is harmed, neither is helped. That is a commensal relationship. A commensal relationship. Some of you might wonder, what is it called if one of them is helped and the other is neither helped nor harmed? That would still be a mutualistic relationship. If one of them's helped, then it's mutualistic. Parasitism. Parasitism, one is helped and the other is hurt. One is helped and the other is hurt. So Necator americana is otherwise known as the hookworm. The hookworm attaches to your small intestinal mucosa, and it basically sucks blood from your mucosa. It gets a free meal, and it deprives you of blood. So you become anemic, it gets fat and fertile and sheds its eggs into your feces. It is obviously helped, you are obviously hurt. That is a parasitic relationship, a parasitic relationship. Now, antagonism. Antagonism. Some species of E. coli that live in your gut are going to have other species of E. coli into the gut from food and other sources. However, the species of E. coli living in your gut have been living there a while. They don't want to share their space with these interlopers. So what do? They make compounds called colicins. Colicins. What do colicins do? Colicins kill other species of E. coli. That's an example of antagonism. The exogenous E. coli species will have trouble finding a foothold in the GI tract because the native E. coli species antagonize them by making colicins. Oh, many pathogenic E. coli, guess what they have in plasmids? They have colicin resistance in many of the plasmids that prevents them from being antagonized from endogenous species. So antagonism can be interspecies in some ways. Contamination. What's the difference between contamination and infection? Contamination means you have an area that was sterile. Introduce organisms into it, it's contaminated. Infection means that those organisms have grown and have survived in that new milieu and are now starting to spread or digit tissue or whatever. Contamination can lead to infection. It doesn't inexorably lead to infection, but it may lead to infection. If your infection is performed by multicellular or eukaryotic parasites, then it's usually referred to as an infestation. An infestation. You don't say a building is infected with rodents. You say it's infested with rodents, right? Infection usually refers to a body, and it refers to viruses and bacteria. If it's protozoans, you usually say, well, if it's multi-metazoan parasites, you usually say infestation, typically. Infection then produces a condition called a disease. A disease. A disease is any condition that produces pain or discomfort by interfering with the normal functioning of any part of the body. A condition, any condition that produces pain or discomfort by interfering with the normal functioning of any part of the body. That's a disease. An infectious disease is a disease caused by an infecting agent. That infecting agent typically being a microorganism. All right, any questions so far? We're good? Okay. An organism that can cause disease in a host is a pathogen. An organism that can cause disease in a host is a pathogen. A measure of the ability of an organism to cause disease is called pathogenicity. Pathogenicity. That's a measure of the capacity of an organism to cause disease. For example, the plague organism, Yersinia pestis. You can breathe in one bacterial cell of Yersinia pestis, and that'll give you pneumonic plague. One organism, that's all it takes. Whereas Actinomyces israelii takes over 1 million cells to cause disease. So which has greater pathogenicity, Yersinia pestis or Actinomyces israelii? Yersinia pestis, because it only takes one. So the smaller the dose required, that's the greater that tendency for the organism to cause disease. That tendency to cause disease, that's called pathogenicity. So this term, microbial count. Microbial count refers to how many organisms it takes to cause disease. There's usually going to be a range, but that is a measure of pathogenicity. Now, this is different from virulence. Virulence. Virulence refers to the severity of the disease. The severity of the disease. So here's just a little example from life. So microsporon mercy, that's hard to spell. Arduinii will cause ringworm of the scalp, otherwise known as tinea capitis. So that's worm of the scalp. And this particular ringworm of the scalp tends to resolve at the onset of puberty. Kids get it if they put in the dirt, dirt in their scalp and what have you. And it's usually not that big a deal. You get redness. You don't have a lot of hair falling out or anything like that. That's about it. This does not cause a severe disease. It's not very virulent. However, Microsporon gypsum this all produces tinea capitis, but this puppy will cause a lot more inflammation and a lot more hair loss. So this causes a much more severe disease. Microsporon gypsum is more virulent than Microsporon arduinii. They're both pathogens, but one is more virulent than the other because it causes a more severe disease. Make sense? Animal passage. Animal passage refers to using a laboratory animal, getting the laboratory animal sick, and then withdrawing blood from that animal, and then getting another animal sick. And taking that sick animal, withdrawing blood from it, getting another lab animal sick, and another lab animal sick, and then another lab animal sick. That's animal passage. Animal passage can tend to weaken the organism. This, in fact, is an old way for making vaccines. The organism weakens, it becomes attenuated. That means the organism weakens. Because as you pass it through the animal, it now starts to adapt to the animal. When you inject it in humans, it now tries to cause disease and doesn't cause nearly severe disease. But you fooled the immune system, thinking it's really sick. This is how Louis Pasteur made the original vaccine for rabies. He passed through rabbits. And then he used the spinal cord from rabbits to essentially purify a fraction that contained the rabies virus. The modern rabies vaccine is not made that way. It's made by genetic engineering procedures that produce a vaccine that's a lot safer. Transposal of virulence refers to an organism that causes a disease in an animal, but it passes through the animal, now made more virulent when it jumps to humans. Example, the bird flu that you saw in Asia. That was transposition of virus from the bird to humans. That bird flu finally, fortunately, did not get over here, but it did cause quite a few deaths in Asia. Very good. So our indigenous flora, we have quite a bit of it. The places where we're colonized include skin and the GI tract. There are areas of our body that are not sterile. There are areas that are. For example, should you expect to find microbes inside your eyeball? No. If you do, that's bad. Should you expect to find microbes colonizing the bloodstream? No. If you do, it's bad. So there are areas that are sterile. There are areas that aren't. There's some microflora that is transient. This is particularly the case when you're little. You'll have a population of microbes that then gives rise to others. Also, if you've had antibiotics, you'll have a transient microflora that will then give way to others. The indigenous flora, this comes from table 15.2 book. I suggest you give that a good look over. It shows you the different types of microbes that you find in various parts of your body. And then there are areas that are microbe-free typically, and please make sure you look at those and are familiar with those. Now, opportunism refers to infections with organisms that don't normally cause disease. Opportunism usually occurs when you get either a failure of host immunity. That's definitely the most common. Or in microbes colonizing places they shouldn't normally colonize. That would be the case with catheters, or with implants, or with PICC lines, or with central lines, or any sort of implant. Those are going to provide microbes unusual locations where they can cause sometimes very severe diseases. That's one of the reasons why burns are so terrible, because now greatly damages skin. They shut down blood flow because they've charred all the blood vessels and things like that. That's why burns can be so susceptible to infections. And then microfloral disturbances, that will be the case usually with long-term antibiotic treatment. All right, we'll hit this on Friday, finish this, get into chapter 16 and the immune system.